Welcome. My name is Alicia Lieberman. I am a psychologist, and for the past 25 years, I've directed the UCSF Child Trauma Research Program at Zuckerberg San Francisco General Hospital, where we treat traumatized, very young children and their families.
And hi, my name is Eddie Machtinger. For the past 20 years, I've been a primary care physician taking care of women living with HIV at UCSF. This is the second of 3 short videos about how telehealth encounters in primary care can be surprisingly intimate and effective. I have found that integrating a few basic psychological principles of trauma and resiliency-informed healthcare can be a very helpful guide to me. The videos address 3 basic questions about how to put this into practice. This second video asks a deeper question. How does understanding trauma guide us towards providing really effective care to our patients right now?
One basic principle is that a particular event can be traumatic for one person, but not for another person, depending on their capacities to respond to danger. The wave on the left, for example, can be an exciting challenge for an experienced surfer, but lethal for an average swimmer. The wave on the right can be an exciting challenge for an average swimmer, but lethal for a young child. Similarly, COVID-19 can feel either like a big, challenging, but manageable wave, or like a potentially lethal tsunami, depending on each person's situation. We're seeing right now that structural inequities, like racism and the lack of a safety net, compound the risk from the virus by creating other urgent, immediate dangers, like, for example, loss of employment, unstable housing, food insufficiency, lack of access to medical care. These conditions create a stormy sea of fear and despair that can overpower anybody. Healthcare providers need to ask about the concrete ways that the virus is affecting their patients so that they can create together a realistic treatment plan. Another important trauma principle is that we don't react only to the current situation. Trauma is a lot like asthma. Current exposure triggers reminders of past exposure and leads to an increase in symptoms. We can think of it as a triangle, linking our adverse childhood experiences, the so-called ACEs that happen to us, with our current distress. Many of the leading causes of morbidity and mortality are associated with chronic experiences of trauma that started when we were growing up. This past January, California Surgeon General Nadine Burke-Harris launched a statewide initiative to apply this important research finding to the primary care of medical patients. Helping patients understand this connection between their past trauma and their current health problems can engage them in their own treatment to reduce self-harming behaviors and increase health and well-being.
So again here, Alicia, I'm seeing what you're describing in my practice every day. Most of my patients are very low income. So their specific circumstances often include living in very close quarters with large families or in hotels with shared bathrooms. And it's becoming very clear that COVID is not an equal opportunity infection, that Black and brown people are dying at far higher rates. COVID-related stress, similarly, is not equally distributed. We, as providers, can play an important part addressing these inequities. One really obvious way to do this is to prioritize reaching out to the patients of ours that we know are living in very stressful or difficult conditions that interfere with self-care, and support them, be there for them, and help them manage their stress and chronic illnesses so that the additional trauma of COVID doesn't lead to lasting damage.